Okay, we're going to go ahead and get started with our final presentation for the day and our final conversation around policy and regulations and reimbursement. A lot of stuff we've already kind of been touching on, but we'll take a deep dive into that now. So I'm pleased to introduce Becky Bounds. Ms. Bounds is a program manager for TexLa Teleheath Resource Center, a division of the Institute for Rural and Community Health at Texas Tech University Health Science Center. Ms. Bounds has 18 years of experience in ambulatory healthcare quality, compliance, and informatics, and is now dedicated to advancing telehealth, particularly in rural and underserved areas. She's going to be walking us through some of the policy and reimbursement considerations for telemedicine, as well as a host of the resources that are available through HRSA and the National Consortium for Telehealth Resource Centers. So, Becky, go ahead.
Thank you, Janelle. Can you hear me okay? Okay.
Actually, you know what? A little closer.
Okay. Okay. So I am with TexLa Teleheath Resource Center, and TexLa is for Texas and Louisiana. We serve all of Texas and Louisiana, but I'm also representing the National Consortium of Telehealth Resource Centers. So we are federally funded by HRSA to provide tools, resources, or what they call technical assistance, outreach, and education to advance telehealth. So this is, so these are free services. And Janelle wanted to make sure that I told you that. There are 12 regional telehealth resource centers across the nation covering every state and some territories in the Pacific Basin. There are 2 national centers, one that assesses the technology, or TTAC, Telehealth Technology Assessment Center. They are physically located in Anchorage. And the Center for Connected Health Policy, which is a wealth of information on federal and policy and state to state. So this is, again, we're HRSA funded. We focus on rural and underserved areas, but we certainly, if I got a little too much animation going. If I get a question from someone in Dallas or wherever, we certainly answer those questions. These are the providers providing services to rural and underserved areas. So our services are technical assistance, and this is in the form of questions via email, through our website, phone calls that say, I want to start telemedicine. What do I need to do? How do I get started? I will tell you that the #1 question I get is about reimbursement, and followed by policy. So we develop educational materials and resources, and then we connect people for different programs like genetic counseling. There's a lot of interest in genetic counseling via telehealth. I'm not personally aware of a program that I can refer you to, but I have this pool of expertise across the country to find a program that I can connect you with. And we develop these fact sheets. One that I get a lot of requests for is funding resources. And then we have the National Consortium of TRC website. There's a lot of resources there, and it will direct you to wherever you want to go across the nation. You can click on that state and say, it'll take you to, you click on Texas, it takes you to me. So I do get calls from, let's say, New York, and it'll be a company that says, I'm trying to move into Louisiana or Texas, and what is the environment like there for telehealth? So I'll explain that. We do have a webinar series, a national webinar series. We sort of take turns hosting that. The one in September was the Houston Ethan program, which is they're using telehealth to better triage patients before they go to the emergency room. And these are free resources as well, these webinars monthly. We have regional conferences. They do look different. Usually we have these large conferences across our region, but some of us are starting to go to more of a workshop type format that's just specific to a state. In a smaller group, that working group that's like really usable information. One of the things that I recently hosted, TexLa recently hosted in Lubbock, was a grant writing workshop for USDA distance learning and telemedicine grant. So I can't do too much of a deep dive into policy because it's so different from state to state. It's crazy. I just didn't realize that until I got into this. I will say federal policy is, and CMS is still, I know they're moving forward, but it's still so complex and so restrictive in so many ways. But 49 states and DC actually have a definition for telehealth. That used to be a lot less. There's a lot of attention. It's one of the legislative issues from state to state with the most attention. Texas just passed a long list of telehealth related bills this spring. 19 states reimburse to the service to the home, others don't. However, even if the state allows it, that doesn't mean Medicare will pay for that. So you have to figure out what the policy is. Well, what will the policy allow me to do, and then what can I get paid to do? And those are your first questions, I would say, when you're thinking about a service model. Don't let the first thing you do be buy a piece of equipment. Think about your service model, what you're trying to do, and then we're a good starting point to say, what does the policy say? Can I see a new patient via telehealth or not? In some states, maybe. In most states, maybe. 40 states have active private payer reimbursement laws and what we call parity law, but they're stated differently. Texas says, if you cover telehealth services, then you shouldn't deny that because it was provided in that way. And they sort of recently strengthened that for Medicaid only. So, but there are some exclusions to parity also. Some states require consent specifically for telemedicine. That's some of the requests I get to. Do you have a sample consent policy, a sample consent form? And I'll send you that. Licensure across state lines, I'd say in general, you need to be licensed in the state where the patient is. Some states have a specialized telehealth license. So I want to practice I want to see a patient via telehealth in Louisiana. I'm never going to physically practice in Louisiana. So I want to get a telehealth license there. So maybe it will streamline it time-wise and be a little less expensive, but I'm hearing from providers that it's really not a significant savings time-wise or money. Just get a full license. Texas also has a specialized telehealth license. New Mexico, Oklahoma does not. So this is the case with nursing, with all the other disciplines that you need to be licensed where the patient is.
Can I interrupt? So the license is MD specific or physician specific?
Whatever type of license it is, nursing.
Pharmacists have a telehealth license?
No, there's not special. Those specialized telehealth licenses are generally just physicians.
That's what I mean.
Medical boards.
One interesting clarification is, I think it's the same 19 states you're talking about. APNs now have freedom to practice on par with primary care physicians, including prescribing, and be able to deliver across all of those states without restriction. That's an interesting evolution that's just occurred.
So the nursing has had compact for a long time.
Yes.
So nursing has been a little bit ahead of the medical boards as far as like I maintain my nursing license, even though I'm not doing direct patient care, but I'm licensed to practice in, I can't remember, 20 something states.
It's 32 states now.
Oh, okay.
Yeah.
that's how long it's been since I looked at that. But anyway, I'm licensed to practice in a lot of states, but physicians are not. There is a medical license compact. In some states have joined it. Texas talks about joining the compact, does not, but there's still these issues from state to state about agreeing to that other states' medical practice board rules. Yeah.
Yeah.
And so no state wants to completely give that up. So occasionally I do hear that there are some issues about where we want a practitioner wants to practice in another state, do telehealth in another state, but it's a very litigious state. And so they refrain from practicing there because it goes against what they're used to doing. And they're concerned with that. But the Center for Connected Health Policy, again, that's your best resource. You can click on your state, and there are 50 state reports of all the telehealth policies, and you can click on your state and find out about licensure, consent, whether Medicaid will cover, whether there's parity law. So some states have specific restrictions for telehealth, like online prescribing. For example, I do use Texas, but because I know the policy here better, we restrict controlled substances for pain management via telehealth. It's restricted, or any drug that may cause an abortion cannot be done via telehealth. And so you have to check with the state to see what their policy is. Some states may control the specialty that can be provided. There are, and I'm not sure if this is still the case, but there were states that dictated how far apart in miles you had to be for the provider from the patient.
Alabama.
And their specific list of CPT codes. So just to summarize Medicare a little bit, because it is the most restrictive, Medicare has a specific list of providers they will pay. They require that the patient be in a health professional shortage area that's also in a rural tract.
Right.
They require that the patient come into a healthcare facility. And with one exception as of July 1 of this year, and that's for opioid and substance use disorder, they will allow the care to be to the patient's home. They have a specific list of codes they will pay, and they, I already told you about the list of providers. So you have to find out, start with Medicare first, especially if that's the patient population you're dealing with. I would start there for what their policies are. And then, so the states, they may specify which providers can be paid, they may not. There are some states, such as Louisiana, that say anyone that's licensed to practice in this state can do telehealth. And this is generally how payment decisions are made. This kind of helps me frame it when I'm thinking about this. As I said, Medicare cares about the patient setting, and that's in a healthcare facility and geographically where the patient is. The technology used, they'll pay for real-time audio and video. They will not pay for store and forward, even though they paid for teleradiology for years and years and years, but they don't define it as telemedicine, so they'll pay for it. They did not pay for remote patient monitoring, but they have unbundled some codes now so that can. Before, you just had to do chronic care management, and that's how you were getting reimbursed for that. But they have unbundled that. And then the provider type and service type. Then commercial, I talked about parity law. The policies may vary. The payer may say, I follow Medicare policy, or I follow Medicaid policy. I would sometimes consider what, when you decide on what your service model is, if you think that's something that you could take to a payer and say, we think that we can save you these emergency department visit costs by doing this model, they may be willing to do a pilot with you. Now, the exclusions to reimbursement by private payers, if it is a self-funded plan or partially self-funded by an employer, they do not come under state jurisdiction. They come under their HRSA plans. They come under, can't remember the acronym, but it's a federal policy that they fall under, and they can carve out telehealth. And they may or may not carve out telehealth. And again, this is kind of summarizes Medicare requirements, patient HRSA rural, designated originating site, CPT codes in a range, and the eligible list of providers. This is the basic billing model for whoever it is. Use the same CPT code or HCPCS code that you would if the patient were there in person. And for Medicare, they no longer have a modifier that you apply, but you use a 02 place of service code, and that tells them that's telehealth. There is a facility fee or originating site fee. So that, let's say the patient comes into a rural health clinic to be seen by the specialist, how many hours away? That facility, it's some recognition that facility, it has put some effort and time into it. They have to have someone to coordinate that, room the patient. We don't expect them to collect our copay for us, but in our telemedicine division, but they can bill this originating site facility fee. Medicare pays about $26 per encounter now. Texas Medicaid will pay $19. Louisiana will not pay it. And then different states may have different modifiers that you will use or attach to that CPT code in addition to what Medicare requires. So Texas, Louisiana, it's a 95 modifier, and then that place of service code 02. School-based telehealth is a different place of service code that says it's in a school. So these are some tips to get started. And before, I will say there's some things that came up here in these discussions. And I thought it was really interesting, Dr. Schwartzberg, that you talked about face-to-face telemedicine. And face-to-face used to be a term we used to distinguish it between an in-person visit and telemedicine. So then they said, no, telemedicine will satisfy that face-to-face requirement to establish that physician-patient relationship. So now we don't use face-to-face so much, but you used it for telemedicine, which I thought was great. So I usually say in-person instead of face-to-face now. This is just some basics, tips to get started. As I said, don't let buying equipment be the first thing you do. Make sure everyone is at the table, and we heard that over here too. IT's got to be there, but you can't have an administrative person decide they want to start telehealth as a clinical service and not involve the medical staff, and it just won't go. And I've seen people do that too. Some of the others, the reimbursement, I know we're moving toward value-based care. I know we are, but as long as this is our bread and butter and this is how we get paid, it's going to continue to be an issue. There are ways we can use telehealth to save some dollars in places and improve outcomes, but we still have to pay attention to reimbursement. There are funding sources. You can get funding to pay for equipment. In some cases, for the administration piece of starting telehealth, you can get you can get funding for the connectivity, but you have to figure out how to sustain the program once the funding is no longer there. So these are general guidelines. I would say one of the first things you ought to do is call the Telehealth Resource Center for where you want to practice, and we will give you some basic answers. We are not, the be-all, end-all consultant for you, but we can get you started and answer a lot of questions along the way. So here is the how to contact us. There's my information here, but and I would be glad to direct you to whatever other telehealth resource center if you contact me. But you can go to telehealthresourcecenter.org, and when you scroll down, there's a map, and you click on wherever, and it'll get you to the right telehealth resource center. And we all work together on a regular basis.
Becky, would we contact you to get signed up for those monthly webinars? Or how
Yes.
do you?
Yes, or if you click on that national site, it's like the first thing you see is the next webinar that's coming up. And
Okay.
you click on that and register, and it'll say, do you want to be added to the mailing list for these? And click yes.
Okay.
And did I hear you right about Medicaid? They don't exactly follow Medicare in that they don't have to be in a shortage area. They do have to, the patient does have to be in an office, the physician office, but they don't have to be in a shortage area.
It depends on the state.
Texas.
Texas, the patient can be at home for Medicaid.
Medicaid? Oh,
Yes.
And another twist on this is that if you station, and CMS qualifies this, if you station, for example, a medical assistant, or even somebody as low level as sort of just an assistant in a nursing home, they have, with the patient on the other distant end, they have been willing to reimburse for that. So their chief concern has been overutilization without result. And the interesting history about this is that the Congressional Budget Office, it's been many years now, has taken a hardline stand that telemedicine, by making it readily available and reimbursing for it, will jack up total budget for CMS enormously, but will not result in moving the dial on population health.
And they're always asking, they want research, they want outcomes, and they ask the telehealth resource centers for that. And it's something we're not able to provide for them.
That's why I say the industry gets an F for this, because they have not done a good concerted job of working with clinical organizations to really design a program to prove efficacy, value, outcome. Even though we know colloquially it's there, it needs to be done. I'm particularly excited about this organization and all of you maybe doing something like this, because in patients with the highest levels of acuity, there is perhaps the greatest opportunity to prove the efficacy of these programs, whereas general ambulatory populations are actually harder to do. So one thing I'd like to maybe bring up, and maybe Janelle, you can address this for the organization. I'm, for example, I belong to a couple of organizations that are in the industry, particularly the Alliance for Connected Care, which is a lobbying group in Washington. You probably know Krista Drobeck. But is ACCC a potential candidate and qualified to actually act as a lobbying force in Washington for some policy change? And is that maybe one of the action items you're looking for at the end of the day? I'm curious.
Well, yeah, for sure. I mean, the other arm of ACCC, aside from education, is our advocacy work. So I think, this is definitely an area we'd like to keep exploring on that front, and would definitely love to hear this group's thoughts about what are the most pressing issues that need to be brought up to Capitol Hill.
So what's coming now is a Connect Act, which will sort of broaden these services that Medicare will cover. So they're really looking at that. I'll tell you, there's a lot of attention on telemedicine, telehealth, and state to state and nationally. HRSA They fund an enormous number of programs that have at least a telehealth component.
Also, the resource centers on the Department of Health resource centers themselves have some monies attached to telehealth directly as well. But I think policy-wise, one of the hardest things that we were able to talk about or to try and bring to policy in general is, I don't know if you remember, Becky, but those who have been involved in this for a while, in 2009, you had to get an actual consent in paper from a patient to do a telehealth visit, which was going against the whole, what's the whole idea here? If I have to bring him here already, then forget about it, right? So then those bills came out and we were able to fight that through. So I think that what you're seeing more and more is more and more lobbying is happening in the telehealth space. One of them, parity laws, for example, that's a lobbying of the insurance companies themselves. And most PPOs right now cover for telemedicine. Most of the Blues, for example, all of the Blues and the Blue Shields and the Blue Crosses are paying for telemedicine in some way or another. Most of them have their own telemedicine programs that they're actually themselves promoting, and sometimes they will go against your institution, so you should know about that as well.
Let me say we did look at that in Texas, because you will call and tell providers when they were getting into telehealth, like, get a hold of your managed care contracts, so find out, make sure they cover telehealth before you get started. And so this is the reality. You call and you talk to your payer rep and they don't know the answer, so they will tell you no automatically. So you have to go up the line to find out if they really cover telehealth or not first.
The wording is so generic in the contracts. Basically, it may or may not, is what it seems like to me,
No.
here in Texas. Yeah, final determination.
That's
Unless you push them on it. And what you do, the best way to do it is to push a code through. What I tell my clients to do is go ahead and do a billing, push a few codes through and see what happens.
Yeah.
Usually you'll get the response that way. So we do that. We just test it because we can't get the right answer. We literally just push it through and test it. But what happens then, for example, I'll give you a very good example. Blue Cross PPO in California has a contract with American Well. So yes, they will cover you to do telehealth if you do it with American Well. If you don't do it with American Well, you cannot do telehealth with Blue Cross of California.
right. So in Texas, this spring, they tried to address that, and they said, if the provider is on your panel and in network, they have a choice of platform that the provider can choose the platform. But we're still getting pushback because I just got an email from providers organization that said they were just told by Blue Cross that no, we're contracted with Teladoc and that's who we'll use. And so I'm like, I'm trying to find the right person to get this to.
This is a thing.
It's a struggle.
Created a monopoly in the telehealth space that is, we don't see that with other things. But it's like people telling you that you can only use AT&T, for example, is pretty much the same thing, right? You cannot choose a phone company. You have to choose a phone company that works in your area.
Right.
It's something that's starting to happen with telehealth. These monopolies, I'm hoping, is going to be the next issue we'll take to states and to say, we need to fight this because it's really not fair. I think companies should have the right to choose the platform that works well with their business case.
Right. There was a lawsuit between Teladoc and the Texas Medical Board over the standard of care. And so the Texas Medical Board said you can't do a telemedicine visit by phone. That's not how we practice medicine in Texas. And so Teladoc sued the medical board and said, you're trying to restrain us from doing our business. And that went on for a while.
And who won?
Teladoc did, but it was actually over a more important major claim, which is that Teladoc maintained in its case that you could establish a patient relationship on a single telemedicine visit on video without having to visit the patient, which is something that the state board was insisting on, is that there was an established relationship in person before you could go on. And then that was another issue.
Yeah, we, the result there was a large group of stakeholders brought together in Texas. It included Teladoc, medical board, family practitioners, different physician groups, and they sat down at the table until they hashed out a definition of telehealth in Texas that they could all live with. And that's what we did in 2017.
The interesting, the dangerous balancing act here is that the CBO is actually correct. The prevailing practices of telemedicine and telehealth for ambulatory care, which are largely phones, text, video, just video alone, have yet to be proven to be effective in actually moving the dial on an actual significant positive health outcome change. And that's in part because there is not enough information for a physician to really go on with those simple methods to actually affect care. I mean, the Texas, in my opinion, the Texas Medical Board was fundamentally correct. We wrote a letter of opinion favoring them, actually. Did you?
We can't.
Oh, you can't, that's right.
We are federally funded and we do not lobby.
You can't lobby.
We can't advocate, but we can educate. That's what we can do.
But what's interesting, what we refer to is, we go back to what the Federation of State Medical Boards as a resource says about what is essential in a primary care exam. And gang, I'll tell you, 99.9% of telemedicine systems in the market do not meet those standards.
Right.
For an ambulatory care.
So from state to state, we do see the same language over and over and over. And that is that however you do telemedicine, it's up to the clinician to figure out if they can maintain the same standard of care. That's the language over and over and over, same standard of care. So I had a question recently, well, how can, a phone visit be done with the patient where they can't see in their ears, or they can't auscultate the chest, or they can't see their throat, and then they're given antibiotics or whatever. So that's where I say the burden is on the clinician to figure out what it takes to maintain the same standard of care as in person. Sometimes that means more equipment. So you have a stethoscope on the patient end, or you have a camera or otoscope on the patient end. But you figure out how you do business, what you would do in a regular visit, and then how can I do that via telehealth?
To assist.
So sometimes that's one of the reasons we say don't go for the big equipment first, because what is it you need? Do you need to spend those thousands of dollars for this extra piece of equipment that you're not generally going to use, or you wouldn't use if the patient were there in person? So figure out what fits. And then when you do have this equipment, let's say a camera, there's a wide range of costs and quality. And so how good do you need? If you're not a dermatologist, or you're not in a field where this image is critical to what you're about to do, then maybe you don't need the most expensive camera.
Yeah. Other thoughts on this? I know some of you probably, your eyes are glazing over on some of these things because it's the policy and the depth and complexity of what CMS has done is absolutely eye glazing. But does anybody have other insights?
I thought go ahead. This is really interesting because this is what when Vanderbilt was developing our outpatient CAR-T program with telemedicine, we were trying to figure out how we could guarantee equal safety to a patient who's in the hospital and outside of the hospital. And so far we've been able to deliver that. One of the things we do is we don't worry about reimbursement. We do a bundled care package. So I do not bill for my telehealth visits. It's what we decided would give us that extra level of safety to have one more point of contact before a patient goes to bed. And we decided that even though we don't bill, overall we decreased the impact of a CAR-T patient on our healthcare system. They didn't have to be in the hospital for 2 weeks. We didn't have to take up a bed. We could use one if we needed one, if it was necessary. We could utilize those resources if they were necessary. But overall, it decreased the impact on our hospital system and our providers and our nursing staff and everything that's always way understaffed and underprovided. But so far, we have been able to do equal care with telemedicine and with our inpatient patients and with our inpatient care. But we spent a lot of time figuring this out, and we have very specific protocols that we go off of to make sure that if someone, crosses that threshold, they automatically come into the hospital, and then we get that in-person, hands-on exam. But it did take a lot of work. Like, we spent a very long time developing very protocolized ways to do this, and our night shift team, the 3 of us, 2 NPs and myself, we had a lot of experience with inpatient CAR T prior to that. And I think the fact that we have 24/7 specialized hem-onc care definitely contributes to our ability to do that and promise that same level of safety for our patients, because a lot of them are very nervous that they're not going to have that same level of care. And so far, everyone's been very, very happy.
Right.
I really appreciate those comments. Yes.
How far away are your patients when you're doing telehealth? But if there's an acute problem, where are they housed?
We require them to be within 30 minutes, just so that we could get those antidotes or steroids in them as soon as possible. We do have we built this off of our outpatient bone marrow transplant program, which requires the same. So we have a lot of community partners with the American Cancer Society, Hope Lodge, and subsidized housing at apartments or hotels so that people are able to be within that 30-minute radius, that if we need to get them emergent care, they're at our hospital, at our facility very quickly.
So I feel like so much of this is discipline specific, right? And in the cancer world, even as I grew up as a fellow, my mentors were all really focused on the physical exam, and I'm an internist, and I still carry my stethoscope, and I still do what I do as an internist. But in the end, I mean, there are even data that show 85% of what goes into our assessment comes from the history alone. And even for me, as like a clinical trials patient, it doesn't matter if I palpate nodes that I think are bigger, or if I think the liver span is longer, or it really all comes down to the objective scan itself. And what the measurements show on the scan, not my particular physical findings. So for me, it's really the history and the scans in the lab. There are acute problems that I think all of our centers, when we would set up a telemedicine program, we have to have some kind of protocol in place to handle the acute. But in the cancer world, so much of what we do, in the hematology world, it's in your head and it's in the lab. It's not the physical exam. In the oncology world, it's, even though I still examine patients, I've got to do it. I can't stand it. I'm an internist. I have to do it. But in the end, that's not really typically the deciding factor on whether or not a patient's progressed or whether they need to continue on treatment. So.
Yeah, that was my question as well. So what I know from my practice is that I get judged on how many points I hit on my physical exam as to how big my bill gets. Did I listen or did I not listen to the number, etc. So for the CPT codes that apply for the telehealth, is there a component that lists the specific organ systems that have been reviewed, assessed, or whatever, or is it essentially?
It's the same CPT codes.
But it's also, you can bill as a time dependent.
Oh, correct. So I think.
So you don't necessarily have to walk through all the physical findings.
So I think it's really different than a clinic.
To maintain that same standard of care, sometimes that requires what we call a patient presenter, someone on the patient end. So this is not an oncology example, but I'll give you one example of something we've been doing with Texas Tech for a number of years. It's probably our longest running telemedicine program. In Southwest Texas, there's a lot of oil field and industrial accidents, and people get airlifted hours away. They get airlifted to Lubbock, Texas for the burn unit. And then they're in the burn unit and they get treated and they get sent home and they live with somewhere close to the border of Mexico. That's a 5.5 to 6 hour drive one way for the follow-up appointment. So several years ago, that surgeon in Lubbock decided to try this telemedicine, and he really did a lot of work to make sure that he felt like that this was what the patients needed and it was the right standard of care and all that. So on the patient end, here's a nurse that's experienced and has worked with this doctor for a long time. There is an exam camera where you can see the wounds, you can see the range of motion. You can, and he can ask all those same questions that he would in person. There's one thing he can't do, and that's the smell of the wound. And he asks the nurse because she's that experienced.
Whether there's necrosis or something like that.
So yeah, a particular type of infection will have a particular kind of odor.
And I think the interesting learning here is that, first of all, the policy environment is indiscriminate about the nature and type of care that telemedicine is involved in. It makes broad-based policy decisions without distinguishing the nature of the care being delivered and the requirements of the care. That's problem one. And the second problem is it has in Washington baked into its brain that a telemedicine session is just a video conference with a patient. That's it. And the fact is, as you just pointed out, you can layer resources as you need for your care environment on top of that base platform. And that's not something that they're considering in their policy decisions. And that's the basis of a lobbying effort right there. Make them smarter about these distinctions in the types of care and the range of capabilities so that reimbursement policies can be set properly. Because right now it's just gross, kind of a gross indiscriminate process.
I want to bring it.
I appreciated the comment about sometimes you just push the bill through a couple times because, and this is also, I think, a place where a lot of academia comes in. We have the bandwidth to do that sometimes. And when we do that, if we gather the data the right way, that data can be put on the legislators' desks to say, now will you cover it? Right. And that's how we make that change.
Yeah.
Karen Ruban's been doing that for a long time, and we've had to do that. I just within the last year got some of our oncology providers to admit that is a valid way to move forward. Yeah. Do it anyway, try to bill it, and then let's change policy.
Right.
I wanted to bring up, before we finish this, I wanted to bring up one issue that's like, seems unrelated, but it's still an issue. There are still areas, especially in these rural and underserved areas, that don't have sufficient broadband. And you have to figure that out. You can use a hotspot, you can use a satellite if needed, but it's not good for lots of video. Usually DSL cable works, but there's ways to get around it, but there's still areas without sufficient broadband. I had a call recently from Fort Davis, and they said, we don't have sufficient broadband out here, and what we do have is extremely expensive. So they're trying to figure out how to bring people into the library so they can connect.
Ajit Pai, who's the chairman of the FCC, who is the son of two doctors, I believe from Kansas, they have put together they have done this repeatedly, but put together about a $600 million fund to invest or support carriers who are going to carry telemedicine services into exactly the areas you're describing. And I did a presentation in front of him and the FCC technical board, and what they really revealed is that they've been pouring money into this for years, into the carriers, but no telemedicine is traveling on those lines, because they have not been making it a requirement. And I think in the next round, they are looking for clinical partners, just like all of you, who will actually commit to delivering services this way. And there is money to be had, possibly from the carrier as a grant, to actually make those funding systems work.
Some states have a statewide plan for broadband. Texas is just at the beginning stages of trying to develop one. So
I did find out that cell phone is something that you see everywhere. I want to talk about two of those programs. So in Alaska, in 2010, we started a program from Juneau Medical Center to the Eskimos, are just about 1,000 miles away from the medical center. Kid you not. I mean, those people were like, I don't know where they were. We went out there with little sleds. What they did is they put a satellite dish in one of an office, was a medical office, just the local doctor, and then so everybody goes to the local doctor, and then they get connected to the medical center, to the specialist from there. And we did something very similar to that in Nevada. But I do a lot of international telemedicine where I can tell you we can use a cell phone, a single cell phone in one place in Kenya, or right now that we do in Haiti or in Guatemala, that pretty much runs the whole clinic for that entire area. We see about 1,500 to 1,600 patients a month on one single cell phone. So it's not like it cannot be done. It's just a matter of being really innovative about how you do it. But a lot of time, all it takes is one good hotspot, and you have yourself a full-blown telehealth program running.
So I think the challenge with that, though, is that and we see this time and time again with our global programs, the United States grew up on copper, and that's where we still have so much dependency is copper and fiber.
Right.
A lot of these developing countries, they came into the market after 3G.
Right.
So they're implementing entire nationwide networks, 3G, 4G networks that have beautiful connectivity.
Right.
We just recently put a battery in a laptop in a remote village in Myanmar. And it's great because it works, but you still have to go somewhere to charge the battery to do the telehealth visit.
Right.
But that's because the cellular networks are that advanced in all these other countries. We have a long way to go in our rural populations.
Yeah.
I spend a weekend every year in West Virginia, in the lower third of West Virginia. I'd have service when I'm on the top of a mountain, and that's it. That's it.
Yeah.
Hotspots don't work.
Yeah, but you can find a local area where you can put a satellite cell phone, and you will get satellite. I can tell you that in Alaska, it's 4 hours a day. So we can do telehealth between 2 p.m. and it's 2 p.m. and 6 p.m. in the afternoon. And that's it. It's only 4 hours a day, but it's 4 hours that otherwise those people don't have any care at all. So we figure at least that. Yeah. But you have to be innovative about that as well and try and go through the barrier. And that's why I think having Telehealth Resource Center or having people who can help you through those barriers, who have done this before, who have seen it before and kind of can give you ideas of how to get past those barriers, whether it's pushing bills or do different kind of, crazy little things. Those are the things that make a telehealth program, work. And sometimes you start them very small with literally 10 or 15 patients and you learn from that and you move it forward. And sometimes you start really large and you scale it backwards. But as long as you do it, I think that's pushing the envelope. Like Gary said, it's really where the value lies, because otherwise we will never know. If we don't do it, we will just never know. And we need to do it.
The best speaker I ever heard was talking about, we were talking about challenges, barriers, and she said, what barriers? Just make it happen. There's a way to make it happen.
If there's a will, there's a way. Yeah, for sure.